Welcome back. This is Christy, and now we're into part 3 of chapter 4, the dreaded AV junctional blocks. And they're really not that bad if you really categorize them in your mind correctly. It's really only a couple of things that you need to remember. So hopefully this video will help a lot of people out that seem to have trouble identifying which type of block a patient might be in. So let's just go through. What we're going to cover is first degree AV block, second degree AV block type 1, second degree AV block type 2, and third degree AV block. And one of the concepts that helps is if you think about the blocks in terms of conduction to the ventricle. If the ventricle, all of the rhythms in this section are going to start out originating from the sinus node through the normal conduction pathway. What ends up happening is somewhere along that pathway, the impulse gets blocked, and sometimes it gets to the ventricle and sometimes it doesn't. And so if you categorize all of the heart blocks in terms of that fact, what you have is in first degree AV block, the signal gets to the ventricle all of the time. So let's go ahead and write that. All of the time. Okay. When we start talking about the second degree AV blocks, categorize them together. The impulse will reach the ventricle only some of the time. Okay. And when we start talking about third degree heart blocks, the signal is never going to reach the ventricle from the original conduction pathway. So the signal will get to the ventricle none of the time. Okay. And so that very well may help. You keep that straight. Keep that in mind as we go through each individual block, that a first degree block, the signal will get to the ventricle all the time. Second degrees, only some of the time. Third degrees, none of the time. So now, with that concept, you just really have to distinguish between what goes on between the two second degree blocks. So let's get started. Okay, we're going to go through and do our systematic approach. What's my rate? 60 beats a minute. Is it regular? Yes, that's regular. Do I have P waves? I have normal P waves. Have one P wave for every QRS complex. Here's where blocks become identifiable. It's all about the PR intervals. Okay, so I'm going to look at my PR interval. Is that normal? It's too long. It should be no more than 0.20 seconds. It's 0.36. So I have prolongation of my PR interval. But when I look at my QRS duration, it looks fine. So it's not wide. So because it's within its normal duration, I know that the impulse got through. Okay, it got through all the time. So by definition, that is first degree AV block. The only thing going on here is prolongation of the PR interval. This PR interval is too long. Everything else meets sinus rhythm. You have ventricles are conducting just fine. Okay, and this QRS right here was caused by this P wave. It just is too long. So this is not the ventricle conducting on its own, because if it did, it would be wide. Okay, let's move on. This is just exactly saying what I just said. Okay, now let's go to the next one. What's my rate? 50 beats per minute. Is it regular? Well, no, it's not regular. It doesn't march out all the way through. P waves. I have a P wave that doesn't have a QRS behind it. Okay, that's going to be significant. My PR interval, it lengthens. My QRS durations are fine. Okay, interpretation. This is going to be second degree AV block type 1, also known as Winky block, also known as Mobitz type 1. Yeah, I know. It has way too many names. Way too many names. I heard a rumor that medicine is going to stop naming everything after the last name of the person who discovers it. I hope that rumor's true. We have, what's going on here, I refer to it in my mind as Winky Bach because I learned the rhyme that your PR interval in Winky Bach gets longer drop. So what you have is prolongation of your PR interval. Okay, and so that is what's going on. You can probably see it better with this one. It progressively gets longer until you drop a beat. Okay, so remember in our slide where I wrote beside the second degree blocks that the impulse gets to the ventricle some of the time? Well, it's not all the time because I dropped a beat. So that meets the definition. It did get through some of the time. Okay, and so the defining characteristics to distinguish between second degree AV block type 1 is that in this type, Mobitz 1 is, or Winky Bach, is prolongation of the PR interval that progressively gets longer until you drop a beat. Okay, and this is, we usually do absolutely nothing for this. This is pretty benign. You just watch your patient, watch the blood pressure, but it doesn't require any immediate intervention. Okay. All right, let's move on. Okay. So let's take a look at this one. What is the rate? It's 40 beats per minute. Is it regular? Yes, it's regular. P waves. I have P waves, but I do not have a P wave for every QRS. And that's part of our routine systematic assessment. Do I have a P wave and do I have only one P wave prior to each QRS? So as you can see here, I have a P wave here and then I have a P wave here. This P wave actually did conduct the signal to this ventricle and this ventricle contracted normally, okay? But over here, there was a block somewhere. So again, this meets the definition of the first slide I gave you, that the conduction doesn't go through the ventricle all of the time, but only some of the time. The difference between this type of block and the first one is that you're not going to see the prolongation. The PR interval is going to remain consistent when you have a PR interval. When you have a PR interval, it's consistent. Okay? It's consistent and it's normal. Okay, it's not too long. So that's fine. The only difference is you have some P's without a QRS. Okay? And so that is how you tell the difference between second degree AV block type 1 and second degree AV block type 2. And this is more concerning. This is a high probability that it could lead to third degree AV block. So this is something that, usually requires medical intervention. Okay. There it is. My PR interval's normal. It didn't exceed 0.20 seconds. QRS durations, they're normal. Okay. You just have extra P waves without a corresponding QRS response. Okay. There we go. And that's just saying, some of the time the conduction's fine and some of the time it doesn't go through. Okay. And this typically occurs, around the bundle branch of his. So, right before you get down to the Purkinje fibers, that's usually the area where this type of block occurs. Okay, let's look at this one. What's my rate? I have a ventricular rate of 40. Is it regular? Yes, it is. Do I have P waves? There's my P waves. Okay. What's going on here is that the P waves have no relationship whatsoever to the QRS complex. And that can be confusing because if you look right here at this complex, you would assume that this P wave conducted this QRS. But that's not true. That just randomly landed there. If these similar P waves had the ability to conduct this QRS, then you would expect within less than 3 boxes to have another QRS right here. Okay, and what is happening is you have total disassociation between the atrium and the ventricle. The ventricle is totally blind to anything the atrium's doing, even though the atrium's beating regularly, and those are pretty P waves, by the way. But the problem is none of these P waves was able to get its signal to the ventricles. Also notice that the ventricles are wide. What does that tell you? That tells you that the ventricles it initiated its own inherent rate. In other words, when the SA node fails, you have the AV node as a backup, and if the AV node fails, then you have the ventricle as a backup as your pacemaker. So because the ventricles could not see any of the atrial activity, it's blind to it, it started acting as the heart's pacemaker, okay? Because it doesn't know that the atrium's doing anything, even though they look pretty. So, it's AV disassociation. If I should have a QRS here, and the QRS should be narrow. I should have a QRS somewhere around here. It should be narrow. Same thing right here. Somewhere about around here, I should have a narrow QRS. So there's no relation. So at the slide I told you, the conduction occurred none of the time. And that is the definition of third degree heart block. And this is, this patient needs to have the Zoll brought out and a transcutaneous pacemaker until we can get a permanent pacemaker placed. This is very dangerous. There we go. And so this is just going to go through the explanation, explaining just exactly what I said. The P waves are just completely blocked. Okay. And so your ventricles just act as the heart's pacemaker and kick in at around 30 to 45 beats per minute. Okay. And so remember, when an impulse originates in a ventricle, conduction through the ventricle will be inefficient. You lose cardiac output, and the QRS will be wide and bizarre. So here you go. You have your QRSs that are too wide. And that's enough for now. Thank you for watching. See you in the next video.